So I'm very pleased to introduce our first speaker for today, Dr. Rubin. She is a highly accomplished reproductive endocrinologist and infertility physician at Reproductive Biology Associates. She holds degrees from Vassar College, Baylor College of Medicine, and the Medical College of Georgia. Her extensive education includes a residency at Emory University and a fellowship at Baylor. Dr. Rubin has received numerous accolades, including Atlanta Top Doctors Award and the Intra-Med Fertility Innovation and Research Grant. She is an active researcher and presenter affiliated with several prestigious organizations. Please welcome Dr. Jessica Rubin as she shares a very timely lecture, Fertility in the News, from Surprising Pregnancies to Controversial Legislation. Dr. Rubin? One minute, we're figuring out the clicker here. A big green button.
Okay, sounds good. Wonderful. Well, thank you so much for the kind introduction, and good morning to everybody. I'm excited to kick off the 2024 annual GOGS conference. And my name is Jessie Rubin. I'm a board-certified REI, and I practice at RBA. So fertility has been in the news quite a bit lately, and so this morning we're going to talk about fertility in the news, from surprising pregnancies to controversial legislation. In relation to this presentation, I have nothing to disclose. So over the course of this morning, we're going to start by reviewing fertility and aging. From there, I'm going to go through and discuss the IVF process. And then I'll conclude by talking about how legislation may impact access to fertility care. I've calibrated the talk so there should be plenty of time for questions if people have any at the end. So let's begin. Let's talk about fertility and aging. So there's often a lot of misconceptions about how advanced reproductive age can affect fertility. And it doesn't help that when we look at the media, we see over the course of the last year or two, Hilary Swank got pregnant and she had twins. She was at the age of 48. Cameron Diaz welcomed a child via surrogacy at the age of 51. And Naomi Campbell had a baby at the age of 53. And if you listen to Naomi, she said, "It's never too late to become a mother." So I think that's a really lovely sentiment, but as an REI, I have to kind of disagree. Sometimes it might be a little bit too late, and it can be really hard to get pregnant. So for women who are 45 and above, as all of these women are, the chance of natural conception is actually really low. It's well below 1%. And even if you do assisted reproductive technology, the chance of pregnancy is still very, very low, less than 5% and probably less than 1%. And so by seeing these celebrities who are getting pregnant and announcing their pregnancies in their late 40s and in their 50s, it's propagating the myth that it's easy to become pregnant, and if you want to get pregnant, all you need to do is IVF. And I have to say, I did not take care of any of these three women, so I don't know what they did, but I can tell you the chance that they got pregnant naturally and very easily was pretty slim. And most likely they either froze their eggs several years ago or they used an egg donor. But they're not talking about it. And so our patients similarly are not getting the message that it can be hard to get pregnant the older we become. So let's get back to the basics for a moment. For normal fertile couples, the chance of pregnancy is pretty low. I know when I tell patients their chance is 20% per month if everything is normal, they look at me like I'm kind of crazy. They're shocked to hear that it's that low. Most couples that will get pregnant within the first 6 months, and fertility peaks at a really young age. It peaks when women are in their early 20s, and oftentimes this is before people are ready for family building. So it's important to know, as women get older, pregnancy rates decline. And unfortunately, with women deciding to have children later, our biological clock really hasn't kept up. And what we see is that spontaneous pregnancy rates are decreasing with advanced maternal age. If you look on the x-axis on this graph, you can see maternal age. If you look on the y-axis, you see pregnancy rate per 1,000 women. And what it's showing is that as women get older, not surprisingly, it's harder to become pregnant. I think what is a little bit surprising is that we start to see the slope of the line increase a lot at the age of 32, and then again at 37, so relatively young ages. So the reason we're seeing pregnancy rates go down as women get older is because there's a change in the quantity and the quality of their eggs. So let's talk about egg quantity. Women have the highest number of germ cells when they're 20-week fetus. They have about 6 to 7 million. By the time of birth, they're down to 1 to 2 million. And by the time of puberty, they've lost about 90%, and they're down to 300,000 to 500,000. By age 40, it's about 25,000, and around menopause, less than 1,000. So it's not a very efficient process, and women are losing up to about 1,000 oocytes every month, even when they don't undergo ovulation. And we only ovulate maybe about 400 oocytes during our reproductive lifespan. In addition to egg quantity going down over time, we also see the same changes with egg quality. As women get older, their egg quality declines. And I like to tell patients by at least the age of 37, at least half of those eggs are going to probably be genetically abnormal. So the reason we see oocyte aneuploidy increasing with advanced maternal age is because of the regulatory mechanisms. They start to become altered in eggs. We see problems with spindle placement and problems with chromosome alignment, and that ultimately leads to errors in meiotic segregation, often with non-disjunction. It's not surprising because egg quality gets worse with age, that embryo quality also gets worse with age. This was a study that looked at over 15,000 embryos that were biopsied to look at the chromosomal competency and see if they were genetically normal. And the older women get, the more likely those embryos are going to be abnormal. We think abnormal embryos most often come from the eggs because eggs are much older than sperm. Since men make sperm every few months, we don't really see generally as much of an impact on embryo quality from the sperm side. So this is an interesting paper because it looks at maternal age and the percentage of embryos that are going to be normal. And the takeaway point is that at the age of 30, about 3/4 of them will probably be genetically normal. And by the time they're 43, it's about 15%. So you see a really big change for women over their 30s in their likelihood of success with treatments like IVF. And so if you have a patient who's interested in doing IVF, age is generally the biggest predictor for success, and time really does make a big difference. So I've shown you that egg quality and egg quantity go down over time. That explains why pregnancy rates go down over time and miscarriage risks go up. And we're seeing that a lot of women are now having infertility. It's about 15 to 20%. And a big proportion of this, not all of it, but a big proportion is due to advanced maternal age. I always kind of struggle with telling patients they have infertility because I think that word is honestly a little bit harsh. And you tell them they're infertile and they think they'll never get pregnant. And that's not true. They're just subfertile. That's probably what it should have been called. But women who are less than 35, if they're not able to achieve pregnancy after 12 months of unprotected intercourse, they would meet criteria for infertility. And for women who are 35 and older, after 6 months. And I do just want to mention that if a woman is 40, you know they're trying to get pregnant, they really will have a high chance of struggling with fertility, and I recommend referring them to an REI sooner rather than later. So because infertility is so common, I do recommend ovarian reserve testing for any women that are interested in future family building. There's a lot of ways that it can be done. The ways we typically use in our office is AMH and antral follicle count. AMH is a simple blood test. It's easy. It looks at a hormone that's secreted by primary, secondary, and preantral follicles. And so it gives us an idea of how many oocytes a woman has. I think there's a misconception that it'll tell them, patients always think they'll know exactly the number of eggs they have left, and it doesn't do that, but it just tells them on the hormone range, where are they? The nice thing about this test is there's no intercycle variability, so it can be checked any time of the month, and that just makes it clinically a lot easier. And the normal value is generally greater than 1, but it really depends on the woman's age to determine what is the normal value for her. The other way I often look at it is with antral follicle counts. This is done with a transvaginal ultrasound where we look at both ovaries. And on the ultrasound, we'll measure the follicles that are between 2 to 10 millimeters and look to see if it looks like a normal ovarian reserve. I want to keep in mind and mention that these markers are not predictors of fertility. And just because somebody has a low AMH or a low AFC, they will go onto a Google rabbit hole and they'll figure out and come to my office and say, I know I'm never going to get pregnant. And that's not the case. It's just as important to know what their testing is, because it will determine how aggressive we are with their treatment protocol, what protocol are we going to use, what dosage of medications, et cetera. I always remind them I have a patient that had an AMH of 0.03, and she got pregnant, and she actually needed no fertility treatment at all. So it's not a pregnancy predictor, but it is helpful clinically when determining a treatment plan. So I think it's important to know that women spend so much of their lifetime being told how not to get pregnant that they often know a fair amount about contraception, but they don't know that when they do want to get pregnant, they might actually have trouble getting pregnant and conceiving. And so it's important to make sure that we're counseling about how reproductive potential changes with age, because most of our patients are getting their information from social media, and it's not an accurate reflection of what fertility is like. It's also good to offer ovarian reserve testing in anybody who's interested in family building, and to make sure to direct them to appropriate medical literature and resources. So when I talk to my patients and they ask me questions, oftentimes they'll say, I learned about it on TikTok. And I'm like, okay, interesting. And there's a lot of information on TikTok. I have to tell you, I don't personally have TikTok, and I did a TikTok search to see what happens when you type in fertility. And this was the page that got brought up, and I watched some of these videos. And while they were all very entertaining, very few of them were actually medically accurate. And so I don't recommend going to TikTok. It is not where generally most information is. I know there is a lot of good information on TikTok. There's a lot of medically inaccurate information as well. And this is where my patients are learning all of their info. So instead, while they're in my office, I direct them to go to ASRM.org, American Society of Reproductive Medicine. If you go on their website and you look on the left, they have a blue box that says for patients. If you click on it, they have patient handouts that talk about everything from basic fertility testing to fertility diagnoses, and it's easy to understand. It's written in a language where patients can comprehend it, and it's medically accurate, and it's free. So if patients are ever asking for information, I do think ASRM has a really good resource, and they have handouts that you can print out for patients even. So now that we've talked about fertility and aging, I think it's important that we discuss the IVF process as well, which is one of the common fertility treatment options. So I always like to start with a little history, so let's start with a little bit of history first. The first IVF live birth was in 1978 in the UK, and trust me, this date is actually going to become important later. And her name was Louise Brown. So if you look at that announcement from the Daily Mail, and here she is, the lovely Louise. She was the first IVF live birth. Shortly thereafter, in 1981, was Elizabeth Carr, who was the first IVF baby in the US. And here's a picture of her on the cover of Life magazine. In what appears to be an IVF lab, she's surrounded by test tubes, some of which knocked over, but it says test tube baby boom, and she really kind of started things off. Nowadays, we see that over 10 million people were conceived with IVF, and it accounts for about 2.5% of US births every year. So there's a multitude of reasons why people might do IVF. Here's just some of them. But common reasons are infertility, fertility preservation, third-party reproduction, and pre-implantation genetic testing. So for infertility, very common reason for IVF, and the common causes of infertility are often female factor, which is about 30%, male factor, which is about 30%, mixed, which is male and female combined, and unexplained, which is still at about 20%. Fertility preservation is also a common reason for IVF, and this can be elective. For example, if there's a woman who's not ready for family building, but she's concerned about her age, she might elect to do what we call social egg freezing. Or sometimes we see it with couples as well. They decide to do embryo preservation, which is fertilized eggs, because they know they want to have biologically related children in the future, but they know they're not ready to have kids anytime soon. I also see a lot of patients for oncofertility reasons. So these are patients who've recently been diagnosed with cancer or some type of condition where they'll need gonadotoxic treatment, and so they'll do fertility preservation before they do those treatment regimens. And then we also use IVF for third-party reproduction. So if somebody is using an egg donor, for example, that egg donor needs to go through IVF in order to collect the eggs. Or if somebody is using a surrogate in order to build their family, whoever is providing the eggs needs to go through IVF so that embryo can be created for the surrogacy journey. And then lastly, we do a lot of IVF for pre-implantation genetic screening. A big thing we're seeing now is women who are advanced reproductive age. They're worried about their risk of miscarriage. They're worried about the risk of having genetically abnormal offspring, and so they're doing pre-implantation genetic testing in order to minimize some of these risks. And then I also see a fair amount of patients who are doing IVF because either they carry an autosomal recessive condition that their partner also carries. For example, a couple that both carry the sickle cell gene, they would have a 25% chance of having an offspring that's affected with the disease. So they might choose to do IVF to do the pre-implantation testing. Or we're also seeing a lot of women who know that they're BRCA. They have the BRCA mutation, and they're worried about the risk to offspring, so they're going through IVF in order to minimize passing down that risk to the next generation. So in order to understand later on in the talk all of the potential impact of laws on IVF and current fertility care, I wanted to just take a moment and review the IVF process to make sure everybody's familiar. So with IVF, women are given gonadotropic medications, typically forms of FSH and LH, and they're administered subcutaneously in the abdomen for about 2 weeks. And the reason is to help recruit multiple oocytes. Over the course of these 2 weeks, patients are monitored with transvaginal ultrasounds and blood work to look to see how they're responding to the medication. Typically, they have about 3 or 4 ultrasounds over those 2 weeks, and that's looking at follicles, which gives us an idea of how many eggs hopefully they're recruiting. And we're checking estradiol levels because as eggs grow and mature, they make estrogen, so we should see that number trending up as well. When it looks like there's a good cohort of eggs, ovulation is triggered, and 36 hours later is when we do the egg retrieval. This schematic on the right shows the egg retrieval. You can see there's a transvaginal ultrasound with a needle. The patient is asleep for this process. We take the needle, go through the vaginal wall, into the ovary, and drain the follicle. All of that fluid will go through the needle, into the tubing, into the test tube, hence why it's called test tube baby. And a scientist, our embryologist, will look through all of that follicular fluid, and they will be able to identify the eggs, and assess them for potential maturity to either be frozen or to be fertilized later. So mature eggs can be inseminated in 2 different ways. One way is through conventional fertilization, basically taking the egg, putting it in a culture dish, and putting it in with millions of sperm and having the best sperm swim inside. The other way is through ICSI, or intracytoplasmic sperm injection. If we do ICSI, which we commonly do, the embryologist will identify the most morphologically normal-looking sperm, pick it up, and inject it into the egg. About 18 hours later, we can check to see if the egg has fertilized, and then fertilized eggs, or what we call embryos, are then cultured until they reach the final stage of development, which is called the blastocyst stage, and that typically takes about 5 to 7 days to reach. If you look at this picture on the bottom, you can see at first there's a mature egg with a polar body, and then it goes on to 2 cells, 4 cells, 8 cells, a cluster of cells called morula, and then ultimately a blastocyst. Here's a video that was captured in the RBA IVF lab using time-lapse microscopy. This is the 2-cell stage. Pretty quickly, you'll see it's now at 4 cell. It's now progressing to about 8 cells, and then it's going to continue on until the morula and the blastocyst. The time-lapse microscopy is an incredible part of technology where you can actually leave the embryo in the microscope, and it's an incubator with a microscope, and they take images every several minutes and then create a video. So the video you saw took just a couple seconds. This was actually about 120 hours, so about 5 days. But it lets you monitor the embryo throughout the entire period of embryo culture, but you don't have to actually remove it from the incubator, so you're not changing culture conditions. So that's a really nice technology that we often use. When couples decide they want to do pre-implantation genetic testing, this is normally done once the embryo reaches that blastocyst stage. And the way that we do it is we take the embryo and we remove out about 5 to 10 cells. Here's another video from the RBA IVF lab, where the embryologist is taking out 5 to 10 cells very carefully from what we call the trophectoderm, which are the cells that will become the placenta, not the baby. We're not biopsying the inner cell mass. But that biopsy is then sent off for genetic analysis, where it can be looked at to evaluate chromosome status. And is it 46XX, 46XY, or something abnormal? When we do the pre-implantation genetic testing and the biopsy is sent off, but the day we do the biopsy, that embryo is frozen, and about 2 weeks later, we'll know the genetic results to know if the embryo is suitable for future transfer. And this is done for a wide variety of reasons, but oftentimes it's to look to see if the embryo is chromosomally competent. It can also be used to look for single gene disorders. So, for example, with that BRCA case, if you're testing for BRCA, you can design a test probe to look specifically at that gene. And it can also be used for HLA matching. So once eggs have fertilized and grown and become blastocysts and potentially genetically biopsied, they then get stored. And embryos are labeled with several patient identifiers, and the location is very carefully recorded. And then the embryos are stored in cryopreservation tanks. The tanks are typically called dewars. They're double-walled, and they're vacuum insulated. And there's a vacuum space between the outside wall and where the liquid nitrogen is. In order to freeze embryos and have them have a high rate of survival, a lot of it is the technique you do it, and also how those embryos are frozen and making sure they stay in liquid nitrogen. So liquid nitrogen is really cold. It's about -320 Fahrenheit and -196 Celsius, which will also become important later on. So once embryos stay frozen, they can be frozen for many, many years until the person comes back and decides they want to use those eggs or embryos. So I've just spent the last several minutes talking you through the IVF process and how it works and how wonderful it is and all of this genetic screening and everything that we can do. But there's also limitations to this technology, and it's not perfect. And in nature, as well as in the IVF lab, most of our eggs are not going to result in pregnancy. And that's probably why women are born with so many eggs. There's a lot of attrition we see throughout the IVF process. Not all eggs we get with IVF are going to be mature and able to be frozen or inseminated. About 70 to 80% on average are. We see that not every egg that's mature is going to fertilize. With normal sperm parameters, about 65 to 70% of eggs will fertilize. And not every egg that fertilizes is going to grow all the way to the blastocyst stage. So I intentionally showed you a video of one that did, but most embryos are not going to grow to the blast stage. And the percentage that we expect to grow is going to depend on a woman's age. So not every egg is going to result in an embryo. Not every embryo is going to be genetically healthy. And not every embryo that is genetically healthy is going to implant in the uterus and result in a pregnancy. And unfortunately, embryonic failure is just a normal part of reproduction, both in nature as well as in the IVF lab. And this is also one of the reasons why women often say they need more than one round of IVF, because they didn't get enough eggs the first time or didn't get the results they wanted at the end of their cycle. So now that we have a really good background on IVF and what it is, including advantages and limitations, understandably, of the technology, I think it's important that we take a moment as women healthcare providers and assess how all of the current legislation might impact access to fertility care. So I like to start with history. We'll start with a little history again. In 1973, there was Roe v. Wade, and essentially that said the constitutional right to abortion for women. In 2018, Mississippi passed the Gestational Age Act, which prohibited abortions in most cases at 15 weeks and above. So then in 2002, there was Dobbs versus Jackson Women's Health Organization. Dobbs was a health officer. Jackson Women's Health Organization was an abortion clinic. And they went to look back and see, is the 2018 law constitutional? And the Supreme Court reviewed it and basically overturned Roe v. Wade. And they said that the Constitution does not confer the right to abortion. And in fact, individual states have the right to choose. So this was a very big landmark decision and started in one state. But if you look at current maps now, this was accessed this month by Planned Parenthood. Now you can see that there's restrictions in most states. 41 states have some form of restriction when it comes to abortion care. And on this map, Planned Parenthood has ranked states everything from accessible all the way to eliminated. But you can see that it's different for every state. And the decision in one state has clearly had a big impact on other states. So where are we in Georgia? Abortion is legal, but only until the start of embryonic cardiac cell activity, with some exceptions if it's a medically futile pregnancy, if it's a medical emergency for the woman, or with rape or incest, as long as there's police reports. So at the 2020 GOGS conference, I was actually up here speaking, talking about the recent decision to overturn Roe v. Wade. And we talked about how there were potential implications of how it might impact fertility. The intended consequence, we all know, was to restrict elective abortions, but it really caused a heightened concern for reproductive autonomy across the board. And the reason it did is because it highlighted the question of when does life begin? And if life begins at fertilization, which some people believe, then technically any fertilized egg or embryo could be considered as life. And if any fertilized egg is considered life, well, how would that impact IVF if these embryos now all of a sudden have personhood? But all of us in this room know that most embryos, even if the egg fertilized, are not going to result in a healthy baby in the end. So there was some concern after the overturn of Roe v. Wade, and there was a lot of concern for physicians. It's not every egg is mature. Embryos are going to arrest. Embryos aren't going to survive when you go to use them in the freeze and thaw. Most do, but not everyone does. And they don't always implant. But there's also a lot of concerns from the patient side as well. So There's often times in the lab where we have to discard embryos that are not eligible for transfer because they carry a genetic disease. So back to that example of BRCA, let's say that a woman decides she does not want to transfer a BRCA-affected embryo, she might decide to discard it. Or if it was sickle cell and the embryo was affected, they might decide to discard it. Keep in mind, I've used two examples where these mutations and diseases can be compatible with life, just because they're common ones that we all see. But a lot of times the diseases we're checking for would result in embryos that are not compatible with healthy babies, and very, very extreme cases. And then we also see some patients that want to discard embryos because they're done with family building, and they don't want to have any more children. But if they're not able to discard embryos, because embryos are fertilized eggs and they have personhood and they are people, then what's going to happen? Are they going to have to keep them frozen forever? Not a great option. Are they going to have to transfer them? Some legislatures have said, well, they should just transfer them all and see what happens. And not a great idea. There's a reason there are guidelines not to transfer multiple embryos. And especially the MFMs in here, I'm sure you guys would agree, you don't want people coming in with multiple gestations. And these are probably women older too, because they finished family building. So not really a great choice either. So where are we? You know, we're 2 years after overturning Roe. What's happened? You know, did anything happen? Or all of these fears that I had, and I know several of you guys had, were they founded, or, you know, did it not become a big deal? Well, unfortunately, it kind of did become a big deal. So in 2024, there was the case of LePage versus Center for Reproductive Medicine. And this case has gotten a lot of attention on the media, especially recently, but I don't think most people understand how the case actually started. So I want to give you a little bit of background on this one as well. So it was started by 3 couples who were IVF patients. They successfully had a baby with IVF. And fortunately, they had extra embryos after they had their child, and they wanted to store these embryos for future use in case they wanted to have additional children. So fast forward a couple of years, and these embryos are stored in their IVF clinic. And the IVF clinic, interestingly, also happens to be hospital-based and is attached to a hospital. Unfortunately, there was a psychiatric patient who escaped from their area. They got outside the IVF lab. Due to an unlocked door, they were able to get into the IVF lab. They walked up to the cryo storage tank. They didn't know what it was, but it was some weird space-looking thing. Decided, hey, let's see what's inside. They opened it up. Remember, it's all stored in liquid nitrogen, so that's really, really cold. So they pull it out. They look at the embryos. They go, oh my gosh, my hand is burned. Drop them. And those embryos fall on the floor. Terrible case, terrible for many, many, many reasons. And understandably, the couples were angry, as they should have been. So they were seeking punitive damages under Alabama's 1872 Wrongful Death of a Minor Act. And they said if that didn't uphold, then they were going after negligence. So the case went to court, and the trial court dismissed it. They dismissed the Wrongful Death Act and the negligence claims. The couples, understandably, were very upset and very angry, and they went to the Supreme Court of Alabama. And the Supreme Court of Alabama reviewed the case de novo, meaning all new, and they said that the 1872 Wrongful Death of a Minor Act applies to, quote, all unborn children without limitation. And that includes unborn children that are not located in utero at the time they are killed. Kind of a bold statement. And they said a civil wrongful death lawsuit is appropriate. And what was so interesting and concerning about this is that this is the first time the act was applied to include an embryo that was not in utero. And essentially it said that embryos have personhood. So the Supreme Court wrote a very long, several hundred-page justification. I won't take you through that, but they said that the purpose of the 1872 Wrongful Death of a Minor Act is to allow legal remedy for a deceased minor. Because the act did not define minor or child, nor state that embryos need to be excluded, it applies. I'm not an attorney. Maybe that makes sense to attorneys, I don't know. But keep in mind, this act was passed in 1872. Remember when the first IVF baby was? 1978. So this act was created over 100 years before IVF technology existed. So of course this act is not going to specifically say to exclude embryos, because they didn't exist. Nobody knew what embryos were at that time. But either way, in vitro embryos now have personhood. And they did acknowledge that there are consequences for IVF, but they said it wasn't the court's role to consider them. So what happened? So most IVF clinics in Alabama, certainly not pleased and very concerned, paused fertility treatment cycles. So they had patients who were literally on IVF medications, getting ready for retrieval, getting ready for embryo transfer. A lot of clinics canceled the cycles. Patients were not able to ship their embryos generally out of Alabama because a lot of the companies that worked to ship eggs and embryos across state lines were now really nervous to do anything with these eggs and embryos. And there was concern about civil and criminal liability for healthcare providers. So there was obviously a very big national response to this. The head of Resolve said, Alabama's Supreme Court ruling is a terrifying development for the 1 in 6 people impacted by infertility who need IVF to build their families. ACOG also issued a very important statement saying, this dangerous decision sets an incredibly concerning precedent for IVF access across the U.S. We have seen state legislatures replicate one another's reproductive health policies in an ill-advised attempt to compete for the most restrictive and harmful laws. And then I think actually ASRM, the American Society of Reproductive Medicine, probably had the most strongly worded statement, and you can tell by their title. ASRM condemns profoundly misguided and dangerous court decision in Alabama. But they said, in its medically and scientifically unfounded decision, the court held that a fertilized egg in a fertility clinic freezer should be treated as the legal equivalent of an existent child or fetus gestating in a womb. The 8 members of the court who approved this decision may view these as the same, but science and everyday common sense tell us they are not. In natural fertility, several eggs are often fertilized before one develops and implants in the uterus. Similarly in IVF, to get the best outcome, several eggs must be fertilized to allow for one with normal growth and development to be chosen and transferred into the uterus. The choice to build a family is a fundamental right for all Americans, regardless of where they live. We cannot, therefore, allow this dangerous precedent of judicial overreach with national implications go unchecked. And that was some of the nicer quotes from the ASRM article, but let's just say there was a lot of national uproar after this case. So where does it stand today? Well, a couple weeks after the Alabama Supreme Court decision, the governor passed legislation that provided civil and criminal immunity to IVF patients and providers. So fertility clinics have now fortunately resumed care. But what hasn't fully been done yet is they haven't resolved the issue of personhood, which is kind of the basis of what started this whole argument. In Georgia, I get asked a lot, well, what are our restrictions and what's going to happen? Because we all know Alabama is our neighbor. And at the moment, there are no current restrictions, but I think we need to be mindful and aware of what's going on in surrounding states. And there are collaborative efforts amongst REIs at several different of the practices in Atlanta, reproductive attorneys, lobbyists that are all working on this issue. So we know that legislation can make a really big impact on access to safe fertility care. And I think it's really fundamentally important that we make sure that patients, our community, our legislatures, everybody is educated on what is the biology of reproduction? How does IVF work? And how can these laws affect access to health care for our patients? And of course, make sure people get out there and vote. So if I had to summarize kind of the takeaway points from this morning is advanced reproductive age can impair fertility. So I know it can be an uncomfortable conversation telling people, you know, age is a factor. I get it. I have these conversations all the time in my office, but it's important for patients to know that if they want to have biologically related children, age does play a role in their chance and success. They need to be educated about what their treatment options are, including IVF. And we need to try to make sure that the legislation is created in such a way where there's safe access to medical care for everybody. So with that, I will conclude. I know it's early, so I thank everybody for their attention, bright and early this morning. And if there's any questions, I'm happy to take them.
Dr. Bonk.
About 2 weeks ago, I heard there was a huge move of embryos out of Alabama. What was that? I mean, was that,
A lot of clinics are thinking, especially in the South, do they need to move embryos and what do we need to do? And, you know, we all know that Southern states generally tend to be more conservative and more restrictive when it comes to fertility care than Northern states. And so a lot of people have been thinking about moving them because of that. We're not currently moving embryos out of Georgia.
Okay, and remember, we have 2 microphones. Yes.
Yes.
And I congratulate you for all this success you have done, and made a lot of very desperate couples happy with having babies. And my question is that I do infertility. My name is Magdi Hanafi from Atlanta, and I do infertility. I get a lot of patients who had treatment by chemotherapy and on early lifehood, you know, even late lifehood for breast cancer and so forth. There is a way of avoiding the damage of the ovaries before chemotherapy, radiation therapy, is ovarian reservation technique. And it seems like it has been ignored. It is well established and studied by so many studies. And I hope that GOGS will adopt some technique or some clinics to develop that to save these people from destroying their ovaries before they get chemotherapy or radiation therapy. It's past time for that. I think we should make a move for that to be established and save these people from having problems. I see the end product of that. For those patients, they come to me, AMH is so very, very low, and they are so desperate. And I think that it's about time to do something about it.
I agree. I think that, you know, we've tried to talk to a lot of oncologists as well, making sure that they refer patients for different options. Egg freezing is not the only option for oncofertility patients. They can also do ovarian suppression with Lupron. There's different choices of what they can do, but patients should have the ability to make that decision, and they should make sure that they're educated. And it can be tricky because sometimes they need to start chemotherapy really quickly, and there's not a lot of time to do it. But I know I always personally will add those patients on. I get them in the office within 24 to 48 hours from the time I get that initial call, because time really is of the essence. And a lot of times we see women come back several years later after chemotherapy and their egg count is really low. Or a lot of women that need to take prolonged periods of tamoxifen, that they'll get diagnosed with breast cancer in their 30s, they'll be on tamoxifen for 5 years, and by the time they come off of it, if they don't decide to do a break, then all of a sudden they're in their 40s, and it can be a really big challenge.
Thank you.
Thank you for your talk. My name is Brittany Merritt. I'm from Savannah. This is a theoretical question, but if we do go down the personhood route, the embryos in our state, that limits our ability, obviously, to unfreeze and discard. So my question is for the women who have embryos, is an off-cycle implant where like the uterus is not primed, is that going to be like the standard of where we're going to move? And what's the pregnancy rate if that happens?
Good question. So there's actually a term for it. It's called compassionate transfer. And essentially a compassionate transfer is an embryo transfer where a woman is not taking any of the hormone medications and you put the embryos back at a time where you're pretty sure it's not going to work. So you time it so that it essentially doesn't work. We do offer compassionate transfers. I certainly hope it doesn't go that way, that we need to resort to that. Interestingly, not all clinics will offer compassionate transfers. And I don't know why. I don't know if it's because it's extra burden on the lab still needing to thaw the eggs and all of that. Or my other suspicion, to be honest, is that all IVF clinics have to report their SART data, and it's their success rates. And compassionate transfers are not intended to work, but they are a transfer. So technically, they do hurt your rates by doing them. So I'm not sure if that's also why some clinics do not do it.
Have you ever seen a pregnancy come from a compassionate transfer?
Thank goodness, no.
Okay.
And I'm not aware of any, but it would be a very, very low chance.
Andy Toledo from Atlanta, Dr. Rubin's partner.
I know you.
I'm not going to zing you with a tough question. I'm just going to make a comment because you alluded to it. Believe it or not, Georgia is one of the most advanced red states in the country when it comes to a lot of these things. That may be hard to believe, but when you compare us to Alabama, we are light years ahead. We have a very good set of guardrails up, and we have legislation and legislators that understand that. You'll be talking to some of them on Sunday. I just want to point out that we learned from the Alabama debacle. We are putting together a collaborative network called the Georgia Fertility Network in conjunction with the GOGS. We're actually part of their task force. And we are trying to come up with methods to make sure that some of the things that you've heard about don't happen in Georgia. So I just want to make you all aware of that we are in a good state. The governor and the attorney general understand a lot of what we do. And at least at this point, with these two gentlemen, they have said that these are not the kind of things that are going to happen in Georgia. So, I mean, obviously, things can change, so we're going to try to do something more concrete. But I wanted everybody in this room to know that. And thank you for bringing it up.
Well, I'm glad you sit on that task force. And this talk was not intended to scare everybody or have them think that I'm coming back in 2 years saying we're not doing IVF or something like that. It wasn't that at all. But I do think we just need to be aware how sometimes the legislation's a little bit unpredictable, and this whole case started from couples that wanted another baby. These were couples that believed in IVF, but it has somehow spiraled so out of control that you don't hear people talking as much about the unlocked door or what happened to the embryos. You just hear that they're people. And so it's just important to be aware, but we are working very actively behind the scenes trying to make sure IVF is safe and we're not shipping embryos out. I personally have embryos. I am not shipping them out of Georgia. At the moment, we're just watching what's going on.
Hi, I'm Jen Lilly from Atlanta. Thanks for your talk. I was wondering, just in referencing age and fertility, I'm seeing a lot more patients request egg freezing. And could you discuss the ages you recommend and some of the success rates and cost, maybe?
Absolutely. So egg freezing is a great option for women who want to have biologically related child but are not ready for pregnancy now. But ideally, it's women that are, in their early 30s, let's say 32, up until 37, 38. We do have women that are older that come trying to do it. We do it for women that are older. But when you see somebody who's 43, 44 and wants to freeze eggs, it just doesn't have a very high success rate. So I generally tell people, if you're 32, 33, you don't think you're having kids in the next couple years, it's the perfect time to do it. I've certainly done it on women who are 40 several times, 41, and it's really just about making sure they're well counseled. Some of the success rates are going to depend on the woman's ovarian reserve at baseline, and then some of it's going to depend on their age, because ultimately it comes down to egg quality. And a 32-year-old doesn't need nearly as many eggs as a 40-year-old when they go through the process. So there's also statistical calculators we can use that will we'll have an idea after screening of how many eggs we think we'll get, and then we can plug it into a calculator and say, based off their age and based off the eggs they get, what are the chances that it results in future children? But It's not a perfect process, and so patients need to know it's a good option as long as they're, generally in their 30s. But it's not a perfect plan, and it's definitely not a 100% fail-safe backup plan.
What's your usual cost range?
Yeah, the way we do cost is we do it all medication included so that there's no surprises. Nobody likes feeling like they're nickeled and dimed. So there's basically 3 tiers depending on how much drugs they need, around $9,000 to $11,000. $9,000 for better responders who need less drugs, $11,000 for the people who need the higher drugs.
Good morning. Thank you for your lecture. We appreciate it. I really appreciated it. My question was, with legislation and disposal of those frozen eggs after a woman has moved through, transitioned through her childbearing years, has there been legislation more recently talking about that?
I'm not aware of any legislation that prevents them from doing disposal.
Got it. And also, what about the cost to our patients when they're holding those embryos frozen for years and not using them and continuing? Do you discuss with the patients how costly that is? That's what is asked of me in the office usually when I start trying to broach the discussion. Well, how much is this going to cost me if I never even use those eggs?
Absolutely. So of course, there is a cost to freeze eggs because it does take, somebody to regularly monitor the tanks, then add the liquid nitrogen and all of those things. It's clinic dependent. So generally they range from anywhere from around $700 per year up to, which is what we charge, I believe, up to, I know some clinics charge closer to like $1,500 per year. And it's an all-in cost, so it's not like per egg or anything like that. It's just, one cost for whatever you have. There are plans, though, with our business office that if you know you're doing long-term storage, you can do it cheaper if you signed up for storage for several years. So a lot of people who know, let's say they're in their early 30s, they're freezing eggs, they know they're not anywhere close to wanting to get pregnant, they'll do like a 5-year storage plan just to save on the cost. So normally it's not too expensive. I have seen a few people's insurance lately that actually covers the cost of storage, but most people's insurance does not.
Good morning.
Good morning.
Juan Pena from Atlanta. Really excellent talk. I'm one of the MFM docs here, and so looking at the videos was really, really, really eye-opening, even for me. I did have a question with respect to pre-implantation testing and what should we be counseling patients once they've achieved pregnancy. It's been my typical practice to encourage them to do some type of serum aneuploidy screening, but I want to see if that's sort of consistent with what people are doing and talking about. A lot of patients end up saying, well, no, I had the embryos tested, I don't want to do that. So yeah, thank you.
Of course, and that's something that, like anything in medicine, you ask 5 docs, you'll probably get 15 opinions. But I do counsel my patients. I recommend they do that testing as well. Our testing is very accurate. It's over 99%, but it's not perfect. So a lot of times people want that extra reassurance. And the other thing, too, that I think gets lost in translation sometimes with physicians telling their patients and patients not comprehending is that we look at chromosomes, but we can't look for things like spina bifida, and we can't look for, omphalocele and, developmental problems. And a lot of times people think, well, I did some form of testing. I don't have to do any testing during the rest of my pregnancy. And that's certainly not the case because we can't look at those developmental issues as well.
Thank you so much. Thank you. That was a wonderful start to our day. And I do encourage all of you that are very passionate about this issue to get involved with GOGS because we're very active with the Georgia legislature. And as you'll see, we'll have 3 representatives on Sunday. So please get involved. We'd love your help.